So thank you for being here, Dr. Hueylan Chern. Dr. Chern is a colorectal surgeon at UCSF who specializes in minimally invasive procedures for colorectal cancer, IBD, and diverticular disease. She has expertise in endorectal ultrasound, transanal endoscopic microsurgery, and sphincter preserving surgery, and her research interests focus on colorectal cancer and imaging techniques. Dr. Chern completed her medical degree at UMDNJ, general surgery training at Brown, colorectal surgery training at UMDNJ, followed by additional oncology training at Memorial Sloan Kettering as well. With that, it's my pleasure to welcome Dr. Chern. Dr. Chern, thank you. We're looking forward to your talk.
Thank you for the introduction and thank you for the invitation. So I am giving this talk on post-surgical anatomy after colorectal surgery. And I would say I welcome questions. It would be fine to interrupt and ask questions to make it more interactive. But I'm hoping, in this talk, we would review some anatomy after some common colorectal operations. There's some terminology that may be worth reviewing, and also sort of the different type of reconstruction that can occur after colorectal surgery and how that translates into your endoscopic findings. So with that in mind, we can start with colectomy. I think these are kind of some of the various kind of operations we'll go over today. And we can maybe start with the right side. So right colectomy, extended right colectomy, I think one that's not maybe covered here is the ileocolic resection. So I think it's probably something we do often for either, large polyps that's not resectable, or cancer, or Crohn's disease. I think when I think about resection, it could be either anatomical or not. So usually we talk about anatomical resection mostly for cancer. So, and sometimes, patients are surprised when I show them the amount of resection that we do for say a right colon cancer. And it's really often due to the lymphadenectomy we do at the time of that colectomy. So the difference between a right colectomy and extended right colectomy would be the blood vessel that we ligate for that tumor specifically. For the ileocolic resection, I think most often it's usually done for patients with Crohn's disease. So you'll see, like, for every single resection we do, we have the choice of doing a primary anastomosis, or we can do a primary anastomosis with a divergent to protect that anastomosis, or we can just form a stoma without a primary anastomosis. So, that's possible for every single resection probably. And that is something that we kind of make a determination on depending on the all the different risk factors involved in forming a primary anastomosis. In this picture, you'll see that the anastomosis is done from the ileum to the transverse colon, and it's a end-to-end configuration, which is actually not that common. Usually, for ileocolic anastomosis, it's done in a side-to-side fashion. But in this one, it's being shown as in end-to-end. So similarly, for the left side or left side of pathology, we can also do a left colectomy or extended left colectomy, again, depending on the blood vessels or the lymphadenectomy involved. Obviously, for benign disease is not as critical. So for Crohn's or for a diverticulitis, those benign conditions, then the lymphadenectomy is not that critical. So it would end up being more segmental and not an anatomical resection. And this is a picture of a sigmoid colectomy, so often done for diverticular disease, and often for the left-sided disease, we'll see more and more end-to-end anastomosis. And you may hear the term subtotal colectomy or total abdominal colectomy. I think sometimes it's confusing when we use the word total abdominal colectomy, which is not the same as total proctal colectomy. So total colectomy means you're removing all the colon, but you're leaving the rectum behind. And a subtotal colectomy would be, you're leaving the rectum plus a little bit of the colon behind. And the subtotal colectomy may be done for patients with, maybe pathology in multiple quadrants or in multiple area in the colon. So multiple polyps, to primary cancer, so something where you will take a substantial amount of colon, but maybe preserving some colon to help with the bowel function. And total colectomy would be done typically for, again, pathology in multiple areas. So it could be like attenuated FAP or Lynch syndrome or UC as a first stage of the ultimate kind of the ultimate kind of treatment. On the right-hand side, you'll see again, this is a total colectomy, so the rectum is preserved in this case, and one can, create a anastomosis between the ileum and the rectum. So that's a subtotal versus total abdominal colectomy. So as I mentioned before, for all the resections, you can consider either doing a primary anastomosis, or you can do a primary anastomosis with a diversion like a protective diversion stoma, or you can just create a stoma without anastomosis. So this is a fairly common operation we do for often diverticulitis, for example. So this is a Hartmann resection. The picture shows the sigmoid colon being resected and the distal part is closed. So that's the rectal stump. And then the proximal side of the sigmoid colon is then created to form a colostomy. So we often, prior to reversal, may have the entire colon and the rectum assessed, and that would require a scope through the anus and also a scope through the colostomy to make sure that no other pathology is found before we do a reversal, for example. So that could be a common request. So we can move on to proctectomy. So anytime you see the word proctectomy, that means the rectum, something is done to the rectum. So, so here are some procedures I can think of where proctectomy is involved. So we'll talk about total proctocolectomy, what a completion proctectomy is. For UC, we form J-pouch, so we can review what it means to do that in 1 stage, 2 stage versus 3 stage. And also what's an abdominal perineal resection versus a low anterior resection. So total proctocolectomy, so kind of thinking back about, what I mentioned about total abdominal colectomy. So the abdominal colectomy means the colon is removed, but rectum is left behind. But total proctocolectomy would mean that the rectum is also removed. So, so I think, for us, it is not easy to go back to the pelvis, so we try to avoid a situation where you have to reoperate in the pelvis if possible. So often if we're we're talking about total proctal colectomy and removing the rectum, at the time of that surgery, we would make a decision to either form a permanent end ileostomy or do some sort of reconstruction. And in this case, the only kind of reconstruction you can do is, since you don't have any colon or rectum left, is to form some sort of reconstruction between the small intestine and the anus. So, and that's what we call a ileopouch anal anastomosis. So this is probably something that's done fairly often for probably IBD would be a very common one, but we do also we can do we use this treatment this surgery to treat those with FAP, for example. So so that's what a total proctal colectomy is. So either performing the permanent end ileostomy at the time, or we would do a ileopouch anal anastomosis. And the word completion proctectomy typically means, the colon at some point was removed, and now we're coming back to complete this process, and that we're coming back to remove the rectum. And again, at that time, we would also make the decision to either form a ileopouch anastomosis, or we just form a permanent ileostomy. So it is very hard, again, to come back to do a surgery after the rectum has been removed and only the anus left, and to expect that it's possible to come back later to form that ileopouch anastomosis. So that is a completion proctectomy. So so J-pouch. So J-pouch is something we do for again, either UC or FAP. Those are probably the prime example of when a J-pouch is indicated. And it is a way to avoid a permanent stoma, although there are definitely significant lifestyle changes with ileopouch to living with a J-pouch. And J-pouch is something that just means the configuration is in a J. There are actually different type of pouch you can formulate. There's like S pouch, W pouch, but J-pouch is probably the most common one that we use. And again, in this case, the ileum is used to create that internal pouch that mimic the rectum and connect to the anus. So we sometimes do it in one stage, which is quite uncommon given the complexity of the surgery and possible, all the potential complication that can occur. But this is kind of how we would form a J-pouch. We fold the ileum in the shape of a J. And so the pouch itself is sort of, it's more that it's kind of two limb. And then you have this anastomosis from the apex of this J-pouch to the remaining cuff. So I would imagine when you're scoping, you will hit a blind end at some point if you're in this efferent limb, versus if you go up the afferent limb. That would lead you to the more proximal small bowel. And so when we do it in one stage, we would do a total proctal colectomy with the J-pouch and without any diversion. So again, not very commonly done. More commonly, if we're going to form J-pouch, we would do it either 2-stage or 3-stage. And what that means is that the first stage is to take out all the colon and the rectum. You would form the J-pouch at the time of your first operation. You would create a diverting ileostomy to protect that J-pouch. And usually that will be about 2 to 3 months of healing time before we come back to do another surgery to reverse that loop ileostomy. So that is what a 2-stage procedure means. I would say this is something we do. I think, for FAP makes sense, I think, to do, and also maybe for those patients with UC and medically refractory but not necessarily for people who come into the hospital with acute flare and cannot be salvaged with either steroid or biologics. So for those patients, we tend to do it in 3 stages if we want to do a J-pouch. Of course, you don't always, J-pouch is something that is complicated. We do have to talk to the patients in detail about what that means. So the 3-stage would kind of give us that opportunity to have that conversation more as a outpatient when things are more settled. So the first stage is actually, and this is probably applied to patients that we're seeing in the hospital with acute flare and just unable to be medically managed. And the first stage would be to take out the entire colon, but leaving the rectum. So that way you are able to do that, have that conversation about whether to have a J-pouch or a permanent ileostomy when they recover from this acute setting of needing a emergent colectomy. So the total colectomy would be done initially. And then the second surgery would then be a completion proctectomy, again, going back to take care of the rectal stump, form the J-pouch if that's what the patient decide. And then at that second stage, also protecting that J-pouch with a loop ileostomy. And the third surgery is to reverse the ileostomy. I would say, given the number of biologics, sometimes patients come in to see me in the office. I would say even for those patients who I'm meeting, in the outpatient setting, I would also consider 3-stage if they have enough. They have many risk factors. So that's a 3-stage operation. So the other operation that we do and you may encounter often is this low anterior resection, and that typically is done for patients with rectal cancer. So that would involve removal of the rectum and also do a primary anastomosis, and often there may or may not be a diverting loop ileostomy. But the anus is preserved and the sphincters are preserved in this operation. The abdominal perineal resection would mean that the anus is removed. So that's the perineal part. So you're removing the anus. So that's usually for patients with distal rectal cancer where we are not able to preserve the sphincter muscle. So it would be taking out usually the sigmoid colon, the rectum, and the anus, and form a permanent end colostomy.
Dr. Chern,
Yes.
I have a question. Sorry, we're just echoing here. So when you're good. When you're looking at these patients from a colorectal standpoint, what size of cuff kind of gives you a sense of like whether to talk to someone about an APR versus LAR, and how as like a gastroenterologist who's initially scoping these patients, what landmarks or things would be helpful in that situation?
Great question. Thank you for that. I would say I think digital rectal exam is probably the most telling one. And so I think when I do a rectal exam, what I'm trying to feel for is whether this tumor is sitting directly on the levator muscle, so the pelvic floor muscle. And if it is sitting right on the muscle, then I think the chance of you saving that sphincter muscle would be low. Versus if you can feel a distance of like 1 to 2 centimeters from the levator muscle or the pubal rectalis muscle, I think then I think there is a possibility of doing a low anterior resection. Historically, people have talked about, well, if you can feel the tumor, you will need an APR. But I think, given the advance of what we can do with staplers and other technology, I think, we are able to still form a low colorectal anastomosis in those situations. I think the other landmark that I think that I use often in my own kind of clinical practice, and maybe something that'd be helpful for you guys to know, is to describe the valves of Houston in your scope, in your endoscopy. And the reason being that the distance is not always super accurate when you describe 10 centimeter, because 10 centimeter for a obese, kind of male patient is very different from 10 centimeter from a very skinny female patient. So because the anal canal distance, length is different for men, women, and body habitus. And also depending on the scope, if you use a flexible sigmoidoscopy, that may or may not be super accurate. And we do use a rigid proctoscopy, so maybe that is a little bit more accurate. But what would be most accurate would be the valves of Houston. So there are 3 valves in the rectum. The second valve is important for us to know, because anything below the second valve anatomically is not intraperitoneal, and it is actually what we would consider as rectal cancer. So like using the valve, it makes it more accurate, because that second valve is always at the anterior peritoneal reflection. Yeah.
Thank you.
So, so moving on to anastomosis. So like, how do we formulate the reconstruct after resection? So there are many types of anastomosis we do, and you may encounter as you kind of scope someone. So we sometimes form a end-to-end anastomosis. Sometimes it's a side-to-end anastomosis. Sometimes it is a pouch, so ileopouch anal anastomosis. We can actually also form a colonic J-pouch for the after low anterior resection. There's also the side-to-side anastomosis, but it can be formulated in the anti-peristaltic fashion or isoperistaltic fashion. And the newest addition is this conal S anastomosis that we do for Crohn's patient. So it would be kind of, I showed the staplers just mainly because I think hopefully that kind of help to give you a more complete picture of how we do these anastomosis. So these are kind of 3 very common type of staplers that we use, either as a TA stapler or GIA or EEA anastomosis. I mean, EEA stapler. So, so like, for example, this is how a end-to-end colorectal anastomosis is typically done. You will see the EEA stapler introduced via the anus and the anvil on top on the colon side. So this is kind of how you will see a lot of the left-sided pathology, either sigmoid colectomy, left colectomy, or low anterior resection. So anything via the connected closer anus can probably be done with the EEA anastomosis. So this is kind of how the circular stapler kind of how it's fired, and it creates two circular disc of tissue that we may hear us talking about donuts in the surgical sense. So this may be how it looks like, in your on your colonoscopy, this end-to-end anastomosis. Usually you'll be able to see kind of the staples actually still. So we actually do hand sew anastomosis also, but it does take longer. So often I would say there's not a huge amount of advantage doing hand sewn. So a lot of time we would just do the staple anastomosis. And this is a very common way of us doing a side-to-side anastomosis. So you'll see two, so you have two blind end of colon that you're trying to join, and we would use a GIA stapler to form that common channel, and the hole itself that we create to introduce a stapler would be closed with the TA stapler. So that is a very kind of classic conventional way of doing a side-to-side anastomosis. I would say that configuration is more like what we will call a anti-peristaltic. So I think endoscopically, it is a little harder for you to go to evaluate the proximal part of the anastomosis, as you have to kind of do this like weird U-turn to kind of look further back. So if we do an ileocolic anastomosis for Crohn's, then I can imagine how that could be challenging if there is a, ileal disease that you're trying to monitor post-op because of this anti-peristaltic configuration. There's a way to do it isoperistaltic side-to-side anastomosis, and that probably does give, there's some advantage for the for endoscopists to survey in the future because it's more of a straight shot. There's also a side-to-end anastomosis that we do. And that usually would be when we would use that when there is a size discrepancy, perhaps, rather than doing an end-to-end. So like maybe ileorectal anastomosis is a very common one. People don't do an end-to-end there. Usually it's done with the side-to-end anastomosis. So and of course, this size staple line is not always going to be like right against the circular staple anastomosis. So there may be a slight, couple centimeter or like 5. So you may have to look into that limb to see the colon in its entirety. So that would be a side-to-end anastomosis. Moving on to this other anastomosis, the ileo pouch anastomosis. So again, I think we looked at this earlier, but it's the ileum that's folded in a J shape. And the common channel is created between the two limbs. So there's a reservoir here. And at the apex of this J is attached to the remaining rectal cuff. So that's a J-pouch. So when you scope, I would imagine if you're in the afferent limb, you'll be able to see the pre-pouch ileum. Oops. Okay, so and we can also do a colonic J-pouch. So for the ileo pouch, usually we form about 15 to 20 centimeter J-pouch. For the colon, is probably more of like a 5 to 7 centimeter pouch. That's being used for patient after low anterior resection to try to help with the bowel function around low anterior resection syndrome. Although I think it's probably only effective for the first couple of years, and after that, there's no difference between a colonic J-pouch or just a straight anastomosis. So, but that just to show that we can form a colonic J-pouch also. So this is a conal S anastomosis, and that's something we can use in patients with Crohn's disease. So it looks like an end-to-end anastomosis. Here you can see that I think this is the ileum, the diseased area in the colon, the appendix. So that's removed, and the way this anastomosis is formed is to bring the two ends together and stabilize the mesentery column, and and then form this hand-sewn anastomosis on the kind of anti-mesenteric side. I think, it's being shown to maybe decrease recurrence. So I have done, several of these anastomosis for patients with recurrent disease. So, but I think with the end-to-end configuration does help with the surveillance, because, yes, we were saying the conventional side-to-side anastomosis in the anti-peristaltic fashion would be hard for endoscopists to kind of look at the proximal ileum versus a end-to-end anastomosis. So we can talk about stoma as well. So there are many different types of stoma, and it could be done. It could be a loop stoma. It could be an end stoma. It can be an end loop stoma, and you may also hear the word mucus fistula. So hopefully we will kind of clarify all those different terminology used. And of course, when we say stoma, it could be small intestine or large intestine. So it could be a loop colostomy, it could be a loop sigmoid colostomy, it could be a loop transverse colostomy. So all of that just add more precision to your understanding of the anatomy. So so this is a loop stoma. So, and that just means, we bring up a loop of either colon or small bowel, and we mature both ends. So when you look at the stoma kind of at the surface level, you may be able to see two separate openings, and one going to the proximal end, one going to the distal end. It's not always that easy to see both limb, because sometimes we form it in a way it looks almost like an end stoma, mainly to help ease pouching for the patients, and also just kind of make it in a configuration that's really kind of easier for the patients to pouch. But it's usually done to divert the stool, fecal stream away from what you're trying to protect. So usually an anastomosis. So that is a loop stoma. And I think if you, I think I'm trying to think of a good example where it may be good to know that you have a loop colostomy. So if someone had a loop sigmoid colostomy done because of obstructing rectal cancer, for example, and without the cancer resected yet, and if you want to evaluate the whole GI tract or the whole colon, it would be helpful to do that, to intubate 3 different areas, and one is to go in to the proximal side, and the one to the distal side, and also through the anus. So it would be helpful to do the scope and that would be probably the most complete scope you could do for someone who had that anatomy. When we create an end stoma, that means the other end is kind of stapled off. So that's either you can call it Hartmann stump, Hartmann pouch, but that distal end is stapled off, and only the proximal end is matured. So that's where fairly common thing in like diverticulitis, Hartmann procedure that we looked at earlier. I think, recently I did a patient with Crohn's disease, and I did a ileocolic resection with an end ileostomy, but I left the entire colon stapled off in the abdomen. So I guess you can still probably survey or evaluate that Hartmann pouch by intubating the anus and the proximal end through the stoma. There is something called the end loop. So even though it has even though it's brought up as a loop, it's really kind of, you can see that it's stapled off here. So it's really done more because the patient's body habitus sometimes may make it hard to create an end stoma, even though that's kind of what it is. Yeah, so basically for patients with thick abdominal wall or short mesentery, where the mesentery is fairly tethered and you can't really bring that staple end of the intestine up to formulate a end stoma. So you end up doing this end loop, as you know, the apex of this short mesentery may be the place where you have the most mobility. And we do try to create the stoma without, you know, with minimal tension, because otherwise the stoma can retract and make it a lot harder for the patients to pouch, and there's more skin irritation. And if it really retract to below the fascia, that's obviously a surgical issue, and would lead to peritonitis. So so there's also this term mucus fistula. So I think mucus fistula essentially is just the end that is not seeing anything, any stool. So it only produces mucus. So that's probably why it's called mucus fistula. So instead of stapling off, keeping the stapled off inside the abdomen, one can bring it up to the skin and also mature it. So there will be somewhat of an access to this area with the scope if you want. And also I think the main reason sometimes we would create this mucus fistula is if there is distal obstruction. So if we don't vent that distal limb, it can be a closed loop bowel obstruction. So that's what a mucus fistula is. Sometimes instead of creating a separate hole to create and mature this mucus fistula, we bring it through the same hole. So this is where we would mature the proximal end as how we do typically, but also vent or mature a little corner of that distal end, just so that we can avoid this closed loop bowel obstruction. And then in this way, we can avoid making multiple incisions on someone's abdomen to create a colostomy separately from, a stoma separately from a mucus fistula. So that is we call it Brisson procedure. So I thought I would just throw in a slide on tattoo, because I feel like it is something could be confusing. You know, I think for me, I think just probably with similar to majority of the colorectal surgeons, I think just distal to pathology makes the most sense. So I think I've seen so many different ways that tattoo is done. Some people do it like just distal. Sometimes people do it both distal and proximal. Sometimes I have seen people tattooing like 5 centimeter distal. So I think ultimately the tattoo is just to help us find the pathology, right? So, and often surgically, the distal margin is harder to determine. So that's why, you know, marking it just distal makes sense. Like, for example, if you have a tumor in the right colon, the proximal margin is always going to be the ileum. So, but the distal margin where we come across in the transverse colon is harder to determine, and especially if it's a pathology, I can't actually see extraluminally. So the distal margin is always the one that's maybe a little harder for us to determine surgically. So that's why just distal to the end of the distal to the pathology would be most helpful. And this is actually a nice photo of how but I think in general is never that precise and discrete. It would be often is more like spread out over a larger area, but either way, it is, I think just the message is just immediately distal is most helpful. So I think that's my last slide. I'm going to stop share and see if you have any questions.